Welcome. How rude. Welcome back, clinical problem solvers. Nice to see all your lovely faces. So many individuals I haven't seen in some time, but welcome back to another edition of RLJ, and the J stands for a special guest. But before we get to our guest, and before we ask Robbie how he's doing, because I don't want Robbie to talk. It's the first time he's quiet. Keep eating. Who is scribing and who is teaching is Ayesha, right? And who is scribing?
I'm scribing today.
Oh, wonderful. Aisha, why don't you unmute yourself, say a few words to the audience, and then Mariana can say a few words as well.
Hi, good morning, everyone. Welcome to CP Solvers. I'm so excited for this session. I haven't attended in so long. And Prof. Rez, welcome. And Robbie, as always. My name is Aisha, and I graduated med school 2 years ago, and I joined CP Solvers back in March, and I've loved every single session. And yeah, thank you for having me.
Hello, everyone. Welcome to CP Solvers. I'm Mariana. I'm a CP Solvers team member since 3 months ago. I'm happy to be here with you, and I'll be scribing today.
Thank you so much, Mariana. Robbie, how are you doing? And then Mike to Jazz to say a few words before we get the session kicked off.
I'm good, thank you.
That's enough. Jazz, tell us how are you and then take over.
I'm doing great. Before we begin, I do wanted to kind of give a little bit of a spiel, more than Robbie's spiel. So I guess, first of all, I just want to say, I always get excited to present, especially to Robbie and Reza, just because even though I learned so much in this case, I just know today is going to be packed with more learning. And second of all, I'm always nervous presenting to Robbie and Reza, not for reasons that you think. I feel like, especially with Reza, I'm already on strike 2. So I feel like if I say something or if I don't present the right case, this is it. And if you ever never see me again, it's because I hit strike 3. So let me just share my screen to explain what I'm trying to say. So strike 1, when the first time I ever presented to Robbie and Reza, I had the audacity to compare Reza to Manu Ginobili. For those who don't know who Manu Ginobili is, he's a basketball player for the San Antonio Spurs. And Reza was, after that presentation, Reza was like, Jazz, feedback. Next time, put up Michael Jordan. And then strike 2, I presented a case of functional neurological disorder. And after we concluded that recording, when I was like, I can't believe I stumped you guys, Reza was like, obviously it was a functional neurological disorder case. So that's all. That's my intro.
Thank you, Jazz, for highlighting how kind and gentle I am, and that I never punish you with any strikes whatsoever. You still have 3 left with me, so maybe it's great that I kick off your excellent case with the first aliquot. Take it away, man.
All right, Mariana, you ready? Perfect. So this will have a total of 5 aliquots. The 5th aliquot is the answer, so 4 aliquots of discussion. So the first one is short and sweet. So this is a 65-year-old male presents with 5 weeks of diarrhea, along with 2 weeks of memory impairment.
Oh, that's a really, really interesting combination of stars, Jazz. I think that the time course here is very, very intriguing, and the initial instinct to try to solve this problem in an elegant manner probably has to be tempered by the fact that you need to have much more clarity on each individual concern. And so we have diarrhea and we have a concern for memory impairment, which immediately translate into the idea that there is a GI issue and a neurological issue. And I think the problem with that immediate reflex is the diarrhea, in many instances, diarrhea is not diarrhea. And in many instances, a neurological problem has nothing to do with the brain itself, but actually reflect a problem elsewhere. So I think the only progress you can make and the only wisdom that you can have in this aliquot is to realize that it really pushes you and tempts you to try to think that there's a primary GI and a primary neurological issue, but you could be easily fooled. And the patient may simply have constipation and constipation and confusion from a systemic issue like hypercalcemia. So my goal is to arm you with how you can be fooled by diarrhea, because I think we've spent a lot of time being fooled by altered mental status as a brain problem, with yesterday being a great example of how a cardiac issue can cause devastating altered mental status. So how can diarrhea not be diarrhea? And I think we actually know this. We have this conversation much more productively with urinary issues. So when somebody says, not that I'm pooping a lot, but I'm peeing a lot, we immediately invoke a differential diagnosis of either true polyuria, actually that you have a lot of water in your urine, too much water, and it's too dilute, or that you have a bladder storage issue as a result of BPH or overactive bladder or a urinary tract infection. And the exact same principle applies to diarrhea. You can have diarrhea due to true increase in water content, analogous to polyuria from the kidney, but you can also have rectal storage issues, analogous to bladder storage issues. And the rectal storage issues may be neurologic in nature, like ileus, like autonomic neuropathy related to constipation with overflow incontinence, or they may be inflammatory in nature, and the inflammation may be reflective of proctitis. Lastly, you don't want to be mistaking diarrhea for hyperdefecation, a marker of hyperthyroidism, which also can cause altered mental status. So my only piece of advice here is don't translate this into GI and neuro. It probably will turn out to be that case in most people, but I think you have to make sure you're not dealing with a bladder, with a rectal storage issue or a systemic cause of altered mental status. Any thoughts to layer on, Prof. Rez?
I just want to highlight what I love that you did, Robbie, is you kept it very realistic despite it being a CPS. And just trying to think of both problems separately rather than leap to a esoteric diagnosis. So that's probably where we're headed.
All right, wonderful discussion there, Robbie. And then great summary there, Reza. So aliquot number 2, Mariana, just unmute me and just yell at me if I'm speaking too fast, or just ask for clarification in the chat. This is will be a big chunk. So patient had been evaluated for diarrhea in the outpatient setting, and in the outpatient setting, a fecal lactoferrin was positive. They also sent stool studies for C. diff, which was negative. Giardia and ova and parasites were also negative. He also stated that his diarrhea wasn't really affected by food intake. And he described his neurological symptoms as more like short-term memory loss, stating, and he went into details about that, saying that he didn't remember going to his doctor's appointments, people visiting he didn't remember people visiting his house, or conversations that he had with his significant other or other people. And when he would talk to people, he would just, stop speaking midway through his sentences, and kind of would say that, he kind of doesn't know what to say next at times. He also started feeling fatigue, but he attributed this to dehydration in the setting of his diarrhea. In terms of his past medical history, he had a history of pulmonary and hepatic sarcoidosis. And in the past, he was on steroids. But his rheumatologist really wanted him to be off steroids because of the long-term consequences, and would put him on hydroxychloroquine. About 7 months before presenting to the hospital, he was kind of like noticing polyarthralgia, and his rheumatologist kind of like worked him up for a whole bunch of things, and most of it came back negative except for an HLA-B27, which was positive. After discussion between his rheumatologist and pulmonologist, they kind of felt that this was most likely to his sarcoidosis. And at the time, to his regimen, they added mycophenolate. So a few months before presenting, he had hydroxychloroquine and mycophenolate controlling for his sarcoidosis. According to the patient, since he's been taking these medications, his polyarthralgia has improved somewhat. occasionally he may have to use celecoxib for joint pain, but he says it's much better than it was before. He also has history of OSA, diabetes on dulaglutide, hyperlipidemia on atorvastatin, Barrett's esophagus on PPI. And he endorses international travel. However, it was not until 2 to 3 years ago. He went to Greece and Jordan at that time. He works as a real estate agent and travels to different states, south, north, east, west, but hasn't gone anywhere in the last 6 months. And he also is in a monogamous relationship with his partner. She recently came back from Puerto Rico for a business trip, but reports she's in good health. He has one pet dog who is up to date in its vaccinations and is also in good health. This is the end of aliquot number 2.
Wow, Jazz. What a case. Expert presentation skills and a lot of data here to tackle. And what I'll do is I'll just comment on the rest of the HPI and then pass the mic to Rabih to cover the background information. And I think we can apply a few general principles in clinical reasoning here. And the one to apply is the sequence of events, meaning what started first. And if we establish the timeline, because this is very much like a New England of Journal of Medicine CPC, you would say 5 weeks ago, the diarrhea started. So the first symptom that this patient had before any confusion that was noticed by him or his significant others was diarrhea. So that's where this journey started. And so the question becomes, are the subsequent symptoms, and there's really 2 systems I'm thinking of, the GI tract, the joints, and the brain. These are like the 3 systems I'm thinking of. But as Rabih mentioned just from the first sentence, you never know if the pathology is actually within an organ or outside of the organ. Is it within the brain? Is it outside the brain? Is it within the GI tract? Is it outside the GI tract? Is it within the joint or is it periarticular? So applying the sequence of events, then the question becomes, is the joint and the CNS a ramification of the diarrhea? And it's really difficult for me to conclude that the diarrhea has somehow led to polyarthralgias. And remember, the polyarthralgias pre-existed the diarrhea and were thought to be from sarcoidosis. I'll let Rabih talk about sarcoid because that in itself is pretty interesting. The other possibility is, can you have one multi-systemic process that's involving the GI tract, the joints, and the brain? So this is where I sort of step back and I anchor myself first in the diarrhea. And I ask the question, what is my approach to diarrhea? And this is I'm just going to share a few key points for early level learners and for all of us. If you haven't heard this stuff, it's going to be helpful. One of the most important questions you can ask about diarrhea, chronic diarrhea. So as you get, every symptom has a different in terms of duration when we put a tempo label on it. For diarrhea, if it's within a week, it's acute diarrhea. As you go between 1 to 4 weeks and more, it's more subacute, and then greater is more chronic. When you're getting into months like this patient, it's more of a chronic diarrhea. A very important question is, does it happen at night when he's sleeping? So Jazz told us that it's not associated with intake because you're already thinking of these buckets and mechanisms of diarrhea, like osmotic, malabsorptive, etc. But it just makes a lot of sense. So if he's waking up in the middle of the night, then you can sort of eliminate osmotic, and you might be thinking of a secretory cause. So that's one really important question to ask the patient. And the second very important question when you're approaching diarrhea is there inflammation or not? And there's a couple ways to go about that. One is systemic inflammation. So you'll look at the vital signs. Is there a fever? Another way is to look at the labs, the blood labs, and that leukocytosis, ESR, CRP. And then the third way to know if there's inflammation or not, look at the stool. The stool lactoferrin is what the urine Luke esterase is. It just tells you that there's white cells in the stool. It doesn't say that you have systemic inflammation, but it's telling you that there's inflammation within the GI tract. So right now, I'm leaning towards an inflammatory cause. I'm not sure how significant that inflammation is. My mind will be looking at the exam and the labs to see if I can add more support to that. Because if you frame it as inflammatory, then all of a sudden, what gets prioritized? The 3 I's, infection. And since it's the tempo is chronic, we're not talking about neurovirus and acute bacterial E. coli or ETEC or anything like that. We're talking about a subacute infection. So less common or unusual organisms, from viruses like CMV to parasites and fungi. The second I, inflammatory bowel disease. Remember, that has a bimodal age distribution. The first peak is higher, but you get a second peak at this age. And the third thing is infiltrative disorders. So can something be infiltrating the GI tract like a malignancy, also causing a paraneoplastic phenomenon in the brain? It's possible. But I have to share one thing with you, and I don't want to spend too much. I know we have 2 more aliquots. When I hear this story, and this is just because I've encountered a case like this through CPSs, if you say diarrhea, joint pain, and confusion, you have to think about Whipple's disease from T. Whippleii. That usually is like a biphasic illness where the polyarthralgia precedes the diarrhea by up to years, and then it's followed by CNS and pulmonary involvement. The last comment I'll make about the CNS stuff, I actually, Rabih, it's hard for me to really frame the problem in the CNS because it's not like our typical acute altered mental status where the patient has encephalopathy. He's actually normal and then has periods of abnormality. It's almost like amnesia. The recent amnesia is how I would frame it. The problem is, I don't even know the term for recent amnesia. I know there's a medical term for it. And then the second problem is I don't have a schema for it. But what I do know is when I hear this, I also wonder about seizure, to be honest, like absence seizure. When we think about seizures, there's focal, generalized. It doesn't always have to be convulsion. And those are the seizures we often miss as internists. So I'm wondering, like, could he have like epileptiform seizure activity that's causing these pauses? I'm joking. I'm pausing like this. I'm going to pass the mic to Rabih.
Like, did Reza just freeze? The problem with Zoom doesn't help me. I'm like, oh my gosh. Anyway, did Zoom have a seizure? Prof, I think that's such a brilliant breakdown of diarrhea to assume a working hypothesis of inflammatory disease. And I agree with you. I think the altered mental status is very intriguing, and I can't wait to see what the imprint is on the exam and the snapshot that we have. And you've already set us up not to get too comfortable if he looks normal now from a mental status, because we know it's intermittent. And I think the major teaching that I can impart with regards to sarcoid is nobody ever is diagnosed with sarcoid. It's impossible to confidently render the diagnosis of sarcoid if the patient doesn't have sustained improvement for a long period of time. So if a patient who was diagnosed with presumed sarcoid is on the beach chilling, having a great time, they probably have sarcoid. But if there's any deviation in their course, especially if there's a deviation that involves a systemic syndrome, you have to go back and say, okay, is this sarcoid with a complication, or is this a diagnosis of exclusion that now I have to exclude and reassess again? And I think that you can call into the question the diagnosis of sarcoid and what may have misled you along the pathway in 2 dimensions. One is in what way is your patient decompensating, and 2, over what period of time? And there's a unique subset of decompensation here in that we have to say this person has not an acute mimicker of sarcoid. This isn't a person who's coming in fulminantly ill and you're having to wonder if there is a acute granulomatous syndrome like disseminated TB that is devastating the patient. This patient has a very unique mimic of sarcoid, if that is at play, which is that this patient has a chronic granulomatous mimic of sarcoid. Now, what are the two most common chronic granulomatous mimics of sarcoid? Prof. Reza and I have seen both of these. The first is foreign body-induced granulomatous reactions. So you'd have to query if there's anything in this patient's conversation with you or their chart that they have silica embedded in them, that they have anything that is a foreign body embedded in them. The other big one that by definition causes chronic granulomatous-like reactions is immunodeficiencies. Chronic variable immunodeficiency causes a sarcoid-like reaction and has to be treated differently with steroids and IVIG. And here there's no prominent signal for any of the two most likely mimickers of chronic sarcoidosis. And so you might have to entertain chronic infections of the granulomatous variety, of which Prof. Rez already mentioned one. There's not many chronic granulomatous infections that can devastate a patient for weeks. But Whipple's is one of them, Brucella is another one, Paracocci is another one. And certain non-tuberculous mycobacteria, not TB necessarily, but other NTM. And then, as we've seen with Jack, actually a long time ago presenting on RLR, we had he described a patient who had sarcoid lymphoma syndrome, where a patient with lymphoproliferative disease turned out to have actually both sarcoid-like reaction from an underlying indolent lymphoma. So what's the world we might enter? We might enter the possibility, if this is somehow linked to his history of sarcoidosis, a mimicker. And the chronic mimickers are often foreign body or immunodeficiencies, but can be less common infections that are indolent and lymphoproliferative disease. This, of course, isn't the only way to connect sarcoid with what's going on with this patient. It's also possible that the connection is through the bridge of treatment, and that the patient is having a consequence either of mycophenolate or hydroxychloroquine, or that this is completely unrelated to his history of sarcoid. So all three pathways are possible, but the major learning point here is you could only diagnose sarcoid in retrospect if your patient is happy with what's happening to them. And if there's any deviation of the course, remember that you've diagnosed a condition of exclusion. And so if your patient's not better, you're standing on shaky ground again. All right, back to you, Jess.
Can I just say, Robbie is heating me up. I was a little cold, but I feel warm from that fire discussion.
Agreed. That was just amazing from both of you. And even I just want to shout out the chat too. This chat's been on fire as well with just some great ideas. All right, Alcott number 3. So before he came into the hospital, rheumatology kind of felt that his diarrhea or loose stools may have been contributing from the mycophenolate. So they told him to hold this mycophenolate and decrease the hydroxychloroquine dose by half. According to the patient, his diarrhea did improve, but mildly. He was still having looser stools. And then he started feeling bilateral lower extremity numbness, tingling, and weakness. It progressed to the point where he felt very unsteady on his feet and required holding on to items or the walls to like ambulate. And then this is when he decided to come into the hospital. He denied any visual changes, no numbness or tingling in his upper extremities, no noticed speech impairment. And he kind of said that his lower extremities feel weaker than his uppers. His uppers are probably closer to his baseline. In terms of his exam, vital signs are completely stable, remained completely stable during the entire admission, afebrile. His chest and exam was good, no regular rate and rhythm, no clear to auscultate bilaterally, no lymphadenopathy in the neck area that was able to be palpated, mild tenderness on palpation on exam, more generalized for his abdomen exam, no rash is noted anywhere. In terms of his neuro exam, there was reduced reflexes in the lower extremities. I would say +1 compared to +3 in the upper extremities. Strength probably like 3 to 4 out of 5, where it was 5 out of 5 in the upper extremities. You could tell that it was hard to tell if he had true sensory deficits, but he kind of did feel like touch was a little bit diminished in the lower extremities compared to the rest of his body. Some basic labs for you all. So he did have a leukocytosis of 14,000, mostly neutrophils. And then just of note, since 2019, he has had like this chronic isolated thrombocytopenia, would hover between like 129 to like 115. And during his hospitalization, it dropped as low as like 89, but would towards the end of his discharge did come back to his baseline. So to put a number value in, on admission, he was 128. His hemoglobin was within normal limits. His CMP completely stone cold normal, INR normal. Lipase was mildly elevated at like 130. B12, folate, completely normal. Iron studies normal, other than an mildly elevated ferritin at 373. LDH normal, CRP normal, ESR normal, ammonia level normal, head CT completely normal. And there's the end of aliquot number 3.
Professor, maybe I can just tackle the neuro dimension on the history and the exam, and then pass the mic to you for the labs and imaging. And I think the neuro dimension is very interesting, because now you're definitely going from a intermittent brain problem to wondering if there is a peripheral nervous system problem. Though the first reflex when you hear bilateral lower extremity symptoms is to ask yourself, are the rules of neuropathy being violated or not? And so the general rules of diagnosing a peripheral neuropathy are that it is slowly progressive, sensory predominant, and symmetric. And here, this is neither slowly progressive nor is it sensory predominant. So you can't reflexively just say, I think this is a peripheral neuropathy. And so you must then engage in a thoughtful differential diagnosis of what causes bilateral lower extremity symptoms. And the most elegant answer is that the patient has a problem in their spinal cord. It is also possible to have a problem in the brain. The legs are represented in the right next to the midline, and so bilateral ACA territory diseases or masses in that area can do it. But here, you then move on to the exam, and the exam shows evidence of lower motor neuron disease with the hyporeflexia. So you immediately say, okay, well, I bet this is in the peripheral nerve. But you haven't fully ruled out the possibility that the peripheral nerve is affected in the cord. And what I mean by that is that there is a cauda syndrome going on, which may be compressive or non-compressive. So in summary, this patient's tempo is not compatible with a rapid working diagnosis of a peripheral neuropathy, which forces us to engage in a thoughtful DDX about the localization of bilateral lower extremity symptoms, which reflexively should prioritize the cord, but can be compatible with a bilateral central brain problem right next to the ACA territories on both sides, or a peripheral problem. The low reflexes strongly suggest a peripheral problem, and the peripheral problem can exist in the peripheral nerves that happen to be in the vertebral column, i.e. the cauda equina, or the peripheral nerves themselves. And I think now you can confidently say that you have a peripheral neuropathy that is part of this case complex. All right, Prof. Rez, I'll pass the mic to you for the other stuff.
Dude, that was incredible. Oftentimes you give me the neuro because I think you're kind to me, but it was awesome to hear you discuss the neuro and localize the lesion. I think the challenging part of Jazz's case right now, it's like really hard to know the exact problem we're solving. Meaning there's so many problems. It's like, where do we anchor ourselves in? And what even makes it more challenging is that some of the problems may be a consequence of the first problem, like the diarrhea leading to nutritional deficiency that can lead to confusion and that can lead to neuropathy. But incorporating the labs. So the white blood cell count, it's really helpful that Jazz gave us the diff on that because we were concerned for fungal infection, and EOs would be a good clue to that. And here we don't have any eosinophilia. I find the platelet count very interesting. And remember, although the hemoglobin is normal, this patient has been having chronic diarrhea. So it could be that that's hemoconcentrated. So it could be that the hemoglobin is also down, which is you'd probably expect in this kind of scenario. But I find that thrombocytopenia really intriguing. And we have to invest some effort in analyzing it because it's low, it's less than 100,000. And quickly, like reflexively, I ask myself, am I dealing with a peripheral destruction? Am I dealing with splenic sequestration, or am I dealing with something in the marrow? This patient definitely needs an ultrasound of their spleen, because you want to know if you are having organomegaly and you have a polyneuropathy and a weird syndrome, you may be thinking about POEMS, for example, which I don't think it is because the diarrhea isn't consistent with that. But if the thrombocytopenia is not due to splenic sequestration, you're going to get a peripheral blood smear, and there's no clues on the peripheral blood smear, and the patient had not been exposed to heparin, then I'm really worried, is this process not only invading the joints, the GI tract, the CNS, but also the bone marrow? That's the thrombocytopenia. As far as the B12, you have to be cautious with B12 because the lab value is not that helpful unless it's really low. And if it's less than 300, you've made the diagnosis. Otherwise, you need an MMA and homocysteine level, and it should be sent in a patient like this. And this patient should be started empirically on thiamine because there's a concern. I think if you even think about nutritional deficiency, such a low risk to just empirically give thiamine, you get a lot of bang for your buck there. The normal head CT, it's almost like saying someone has a normal chest x-ray when they're coming in with shortness of breath. I really am looking forward to the MRI. I thought Robbie's thought of cauda equina. I spent 20 hours thinking about cauda equina and it didn't come to reflexively, but I love the idea of an MRI of the spine to make sure. If we rule out the cauda equina, this is making you think of not only the peripheral nervous system, but specifically the peripheral nerve, not the junction, not the muscle, because the reflex was down. When you have like a primary muscle pathology, as long as you don't have atrophy, the reflex will be normal. And junction problems don't present symmetrically like this. So if we are in the peripheral nerve, just based on the tempo and the red flags mentioned, we're really worried about a demyelinating process. And see how we can explain almost everything with diarrhea. Diarrhea, nutritional deficiency, the cause of diarrhea causing chronic inflammatory demyelinating polyneuropathy. And quite frankly, in a lot of people, that probably would be the answer. But in this case, it's tough to land on that because of this confusion that the patient's having, the arthralgias that the patient's having. So there's some things that say, look, you got to go against base rate. You got to go against the peak of the apex where the topography is. That may have not made any sense to you, but look at Zalvin's tweet from today, and then that joke will land pretty good. So where would we go from here? I think once you think neuro, and neuro has to be evaluated, you're thinking, I need an MRI of the spine. Am I going to need an EMG nerve conduction study? Am I going to need an LP? Am I going to need an EEG? And honestly, I wouldn't be surprised if all of that is completed. I would get a peripheral blood smear. I would do an ultrasound or a CT scan of the abdomen and pelvis. And then I would, that would allow me to decide what's next. Robbie, any other studies you're sending off this?
No, I love it. I love the analogy also of the MRI and the head CT and the CT chest and the X-ray. That was awesome. And I completely agree with you. I think that, I'll just be honest. I'm not even trying to solve this problem. My mind can't start to think of individual diagnoses. The problem is still like San Francisco fog. You can't see clearly through it. I'm waiting for Jas to shine some light literally on the core essence of this case.
All right. Yeah. Amazing discussion. So I feel a little bit validated because this was like a very confusing case in terms of like, we didn't know, when I say we, myself, the neurology team, we didn't really know what to anchor on and what to really pinpoint just because there was so much information and we don't know what was relevant or not. So feeling a little bit validated, but hopefully some answers or some clarity for the next aliquot. So ANA was negative, anti-double-stranded DNA was negative, SSA, SSB was negative. A CT enterography was done considering the diarrhea and mild abdominal pain. No infectious / inflammatory or inflammatory process was noted on the read. Histoplasma was negative, HIV negative, calprotectin within normal limits, quantiferon negative. I'm going to repeat that again. So Mariana, she's keeping it up. Perfect. Okay, great. Great job, Mariana. And then MRI, normal. Mild scattered T2 hyperintensity in the white matter consistent with chronic microvascular ischemic disease was the read. An LP was done. It was significant for elevated protein at 64. Glucose was normal, 44. Cell count clear and colorless. There was elevated nucleated cells at 13. Gram stain negative. IgG index was normal. An ACE level was sent both on the CSF and serum with normal limits. A meningitis and encephalitis panel was sent. Both of them returned back negative. This includes Cryptococcus neoformans / Gattii, CMV, enterovirus, E. coli K1, H. flu, HSV1 and 2, HHV6, human paraechovirus, Listeria, Neisseria meningitidis, Strep agalactiae, Strep pneumoniae, and Varicella zoster. So all of those were negative. The VDLR was sent, was negative. We also repeated a panel again, just to be thorough, and it was negative. That is the end of this aliquot. And the next aliquot will reveal the final diagnosis.
Wow. I know one thing with certainty, that this is not lupus. I'll start my
I appreciate the pause there too, by the way. That was really good.
All right. So Robbie, I think we should tackle this together. And and Jazz, are those nucleated cells, were they lymphocytes? Is that fair to say?
Hold on, let me look that up. I think yes,
okay,
lymphocytes.
No worries. Thank you.
Yes.
Appreciate it. I think okay, I'm just going to share my thoughts and then pass the mic to Robbie to share his thoughts. For me, I think the frame for me now is a MRI negative, CT enterography negative, CNS, gastrointestinal, rheumatic, peripheral neuropathic process. And honestly, like, I think we got to explain the diarrhea and the CNS dimension of this case, as well as the peripheral neuropathy. Like, and the things that come to mind with MRI negativity is like, is there a nutritional deficiency? Is there a perineoplastic phenomenon? Is there prion disease? So Robbie, I'm really going back to our CNS vasculitis case that we recently had. And I'm like literally going through, because we have this lymphocytic pleocytosis in the CSF. We have no clue for like a strong clue for infection, though we know the test characteristics of a lot of these studies aren't perfect, but I'm not getting the vibe. I mean, TB is notoriously very difficult to diagnose, and it can do all of this. And sometimes you need repeat samples of the CSF. Some of these tests, you need to send 10 cc's of the CSF to have accurate test characteristics. But I really want the final diagnosis to explain the diarrhea. And I would send all the nutritional stuff. And if those are negative, then I'm either at like a perineoplastic phenomenon. So I would send an LDH, because intravascular lymphoma can do this, especially if there's splenomegaly and there's thrombocytopenia. I would do an upper endoscopy and biopsy of the duodenum for Whipple's disease. Or I wouldn't do it, but I would suggest it and see what other people thought. But I was curious, like, where are you? Are you now ready to solve a problem, or what thoughts are you having, my friend?
Oh my gosh, I think that This is, I think, Prof. Rez, the way that you broke it down was just so cool. Like you start off with MRI negative brain disease as like the first thing, and then you're like, I think the diarrhea is key, maybe the neuropathy is key, but like the center is MRI negative brain disease. And I completely agree with you. I think that it's hard to hear about a 65-year-old person who's stopping speaking in the middle of sentences for that not to be the crux of the problem. And for me, I feel very lucky that we're having this conversation because in large part of the diagnosis that we missed or sort of missed at Kaiser Oakland, where I spent a lot of time thinking about like MRI and brain diseases. And I think fundamentally, just to reflect on that briefly, and I think we'll actually have to talk it out again, because I'll just share why I think there are so many remaining possibilities, so many diseases compatible with this. And that's the argument that I'm going to try to make. And then maybe we can try to see if there's something about this case that helps us pick between these categories. But if you are starting overall with MRI, and I'm thinking out loud with everybody, MRI negative brain disease, I think you go back to the original tension of, is this intrinsic to the brain and the MRI is negative despite that? Or is this actually a reminder that it may be a subtle extrinsic disease? So you might say, okay, I'm going to assume that since the MRI is negative and an MRI is a really good test, catches most things, let's assume this is a subtle extrinsic disease. And what kind of subtle extrinsic diseases can occur? And it's helpful to further break those down because there are many into inflammatory extrinsic diseases and non-inflammatory extrinsic diseases. And in the inflammatory category, Prof. Rez, I think you hit the nail on the head. Intravascular lymphoma is a big one. And then a lot of the genital neoplasms with paraneoplastic phenomenon. So breast mass, not relevant in this patient, may not be appreciated on imaging. A testicular tumor may not be appreciated on imaging if dedicated imaging is not done for it. So the two cancers that are extrinsic are lymphoma, intravascular lymphoma, and testicular tumor in this person. In terms of the autoimmune categories, there are many subtle autoimmune diseases that can be extrinsic to the brain. And the most notorious, I feel like you mentioned a lot during our last conversation, Sjogren's, which is much less likely here given the ANA negativity. But Kirtan fooled us with a celiac disease case, another example of an autoimmune disease that can be extrinsic. And here, a celiac might be a great explanation for the diarrhea that this patient has. In terms of the infections, I think that really there are two big ones that I will always hold dear to my heart. One of which you already mentioned, which is Whipple's disease, and the other one, which has fooled us before, with Will from UCLA presenting an epidural abscess, presenting with altered mental status. So you can see how there's so many different compatibilities that are inflammatory. And now if you go to visit the non-inflammatory extrinsic causes, most of those things are centered around the GI tract. Either GI tract nutritional deficiencies, which the one we haven't tested for here is pellagra or B3 deficiency. And then a lot of medications. So I've had a patient who was taking bismuth as part of their like GI upset. It gave them diarrhea and it caused them to get confused. So that's definitely a possibility. And then I think a lot of toxins can do it, which I think I'm not saying much about that, Prof. Rez, for a very specific reason, because it may or may not involve a case that we're presenting to you in the future. Anyway, so that's the like extrinsic category. If you believe that there is intrinsic disease and the MRI is negative, I think there are two really important considerations. The first is prion disease. Believe it or not, some prion diseases can cause neuropathy and diarrhea. And then finally, I think autoimmune encephalitides. And I think the reason that I'm more inclined to think that the problem is actually in the brain is the patient has inflammation in his brain with the lymphocytic pleocytosis. And so I think that I think any one of those considerations is possible, but if we prioritize the presence of the diarrhea, I think nutritional deficiencies merit a lot of consideration. I think that bismuth toxicity is an important one to think about too. I think autoimmune encephalitides and prion diseases are really, really important. And there is a autoimmune encephalitis that's characterized by a diarrhea, and it is a notorious Whipple's disease mimicker. It's called anti-DPPX encephalitis and causes neurocutaneous disease. So for me, Prof. Rez, am I confident in where the answer is? Absolutely not. I think there are many rare diagnoses compatible with this case, and I think the answer will just tell us what was signal and what was noise? Is the diarrhea really valuable? Is the neuropathy really, really valuable? But I can think of 10 things that are compatible with this case, and we'll learn a lot from what features I probably should have emphasized and what features I should have ignored, or a new diagnosis that I've never heard of. Where are you at?
Right there with you. Very interested to hear what Jazz has to say, and then reflect on the case to see what was the foreshadowing to that, assuming we know what the final diagnosis is.
All right. So I have the final diagnosis, and I also have like a good chunk of teaching points, if that's okay with you all. Okay. So all of this, you guys basically really validated us in our workup, because we both, one thing I really loved about this case is the neurologist I worked with was so down to earth. And I remember we like called each other at 2 p.m. and we're just like, okay, what's going on with this patient? Like there's a lot of things that don't make sense. And here I am, a brand new hospitalist, and for someone to just, chat with me and just kind of go through a differential was such a great learning experience. So shout out to that neurologist. He definitely made this case a lot more educational. We considered everything. We were about to send out the paraneoplastic panel, just because, with how he presented. His T-Whipple CSF PCR came back negative. We were getting him ready for a EGD for biopsy to see, because that is still the gold standard of diagnosis. But then his IgM, IgG, West Nile virus came back positive in his CSF. So it was very shocking, because, so my teaching points stems from a JAMA article that literally was published in September, a month ago. And it basically talked about how we're like really underdiagnosing or missing a lot of West Nile cases. And basically CDC in August of 2023 released an update that said that every state in the United States has a case of West Nile virus in 2021. And what was and basically from those over 3,000 cases that were logged, almost 70%, so 69% were neuroinvasive. And in 2021, what was unusual was there was these 3 counties in Arizona that had almost greater than 50% of West Nile cases in 2021, and contributed to more than usual rainfall in Arizona, which is typically a dry state. It is one of the most common mosquito-borne illnesses in general. And the CDC thinks that up to 140,000 cases just fly under the radar, because it's your flu-like symptoms and fever, which this patient didn't even have. So it's really crazy. And the JAMA article highlighted that the climate change has been one of the main reasons why West Nile virus is spreading to the northern states. So for context, for those who don't know, I'm in Rochester, New York. This is, we're known for more snowfall and colder weather. And they also feel that the warmer weather, more rainfall versus snow, shorter winters, longer summers, this all creates an environment that is way more conducive for mosquitoes to breed, propagate, and then expand beyond their typical environments. And then according to the CDC, about 20% who are infected with West Nile viruses will develop that fever and flu-like symptoms with fatigue and weakness, sometimes persisting for weeks or months. Less than 1% of people will develop neuroinvasive disease. Typically, it typically presents with meningitis or encephalitis. However, just like polio can have acute flaccid paralysis, but it is rare. And older adults or people who have comorbidities or are immunocompromised, like our patient, are at more risk for neuroinvasive disease. Typical neurosymptoms are like your headaches, high fever, neck stiffness, stupor, disorientation, but can present with just isolated cognitive symptoms and memory loss. Patients who do report substantial functional and cognitive difficulties for up to a year following acute infection. So it can take about 6 to 12 months for them to actually come back to their baseline. About 1/3 of those patients do recover back to their baseline, 1/3 about modestly improve, and unfortunately 1/3 fail to improve. The diarrhea typically is 10 days. This patient had it for 5 weeks. It says in the literature, and sometimes it can be prolonged in some patients. We have a feeling that diarrhea was probably multifactorial, probably started off with a viral illness, maybe had weight loss, side effects from the medications. His diarrhea did improve during his hospitalization, so that was also reassuring. The other thing to comment on was the MRI, because that was my perplexing thing. Is like, why didn't the MRI show anything? MRI can be normal up to 7 weeks after infection. And the neurologist also and the ID doctor both felt that the time that we got the MRI would have been sufficient of catching it, because they think that he probably has had this for the last 8 weeks or so. Then it got me digging further, and there was a journal in neuroradiology that they examined 20 patients with neuroinvasive West Nile virus. 5 of them completely normal MRIs. So it is definitely possible to see that. My reflections on this case is basically what goes back to Dr. Gurpreet Dhaliwal's ground rounds at MGH a few weeks ago. I'll be completely transparent and vulnerable. I jumped on that Whipple's bandwagon so fast. And being a new hospitalist, I felt very uncomfortable to mention that to the specialists, because I felt like I don't want them to say, who's this clown going around saying this might be Whipple's? But they made me feel validated. They're like, that's a very real possibility. But going back to Dr. Dhaliwal's lecture, you know, his take-home point was, to be a master clinician, we have to be better at knowing the common conditions, but then also knowing the atypical presentations of a common condition rather than a zebra. And I think this is a great example of that. I mean, West Nile virus is not common, but it is more common than Whipple's disease. So a lot of reflections, so much learning. And I know you guys didn't say the specific diagnosis, but you're throughout your discussions, you hinted at so many different elements that we did not have that insight, except for the neurologist who and in terms of, I'm sure there's a lot of questions. I haven't opened up the chat yet. So where could he have acquired this? He walked his dog. That was a daily routine that he had. And probably got bit by a mosquito that we just brush it off. It's a mosquito bite, whatever. And that's where other than that, no travel to any specific areas.
Can I just say one thing? Because I know we got to get to Aisha's teaching points. If you guys, first of all, Jess, thank you so much. Incredible case, great teaching. Those patients are lucky to have you as a doctor. But if you go back and rewind this episode, if you're watching this on YouTube, go back to Rabih's initial discussion. What did he say? That the reason I got this case wrong, primarily, I don't think of West Nile virus often, but I have an illness script for it, is because I put too much emphasis on the diarrhea. If you remove the diarrhea completely, this is very compatible. Like I would have said on the CSF, make sure to send West Nile virus. Like we've seen this so many times. So if you rewind it to what Rabih said, he's like, be cautious with that diarrhea. It's so, and I think that was key, Rabih, to preventing premature closure.
Prof. Reza, I can't, I'm so struck by so many elements of this case. And I think it's a reminder that if you don't know what problem you're solving, it's really, really hard to try to come up with a thoughtful analysis. But honestly, what struck me is just how the deep dive, Jess, that you did. How many journal articles did you read after this case? Seriously, how many?
4.
Oh my gosh, that's incredible. I mean, that's it, right? I really, really admire that. That's the key in this case. I think in real life, we thankfully have an appropriate reflex to like dive deep and get a lot of testing for especially an immunocompromised patient. And I think the major error that I made in my teaching was I completely forgot when we said MRI intrinsic to the brain, forgot to actually apply that to all categories of the brain, because you can have MRI intrinsic parenchymal issues, which is what I mentioned, but there are also MRI negative intrinsic vascular diseases. and MRI negative intrinsic meningeal diseases. And I completely forgot that category of how can you have a normal MRI and have an intrinsic problem? Primary meningeal issues, of which West Nile is a great example. But at the end of the day, I had a very hard time with this case, in large part because the problem was so diffuse, and knowing which one to heavily invest in was very, very tough. But in retrospect, if you have an immunocompromised older adult who has a brain problem that is MRI negative and has lymphocytic pleocytosis, I think an atypical presentation of an arbovirus is a very, very important consideration. And for those of you who are interested to read more about this, there are 2 or 3 NAGM cases of neuroinvasive West Nile disease in patients who are immunocompromised who present very atypically and whose diagnostics are even more complicated, because sometimes, Jas, they're so immunosuppressed that their serologies are negative, and the only way to diagnose it is by brain biopsy. So I really, really appreciate you teaching us how the epidemiology and the landscape of West Nile is changing. And I think another variable that I'm going to study more is how is the fact that this person is on steroids, mycophenolate and Plaquenil, how does that influence the case? And I'm sure it probably did to some extent. Really, really educational. And I think it's strike 3 though, unfortunately, Jas. A good thing he's gone.
Reza left.
Well, thank you. Yeah, go ahead. No, please.
No, I just want to say I'm sure everyone wants like follow up. So I followed up on him after he got discharged. He saw neurology and ID in outpatient clinic. They did one thing I didn't mention just because I didn't think it was that relevant. We did a MOCA on him in inpatient, and he had a score of 23 out of 30. And then they did one again in the outpatient setting, and it's improved to, it was 21 in the hospital, now it's 23. So he's slowly improving. So they're going to watch him for the next 6 to 12 months. He is going to take acyclovir for the indefinite, like for the next few weeks. I think they just want to be a little bit more cautious with him. So that's the other thing I wanted to share, that all of those things you guys mentioned, vitamin deficiencies, all of those things were on our list to explore. But when that came back positive, it explained majority of his symptoms.
Absolutely. Awesome case. Really, really educational. Can't wait to reflect more on it. All right, Aisha, take us home, please.
Hello, everyone. Attending Jas, that was such an amazing case. I'm not even the least bit surprised that you brought such an interesting case. This is probably the best case for you to get your 3rd strike in, so good job. Okay, so starting with the teaching points, we have a 65-year-old male presenting with 5 weeks of diarrhea along with 2 weeks of memory impairment. So starting off with the chief complaint, we want to think about if this is signaling to a primary GI indication issue or a primary neuro issue. And when we're thinking about diarrhea, is it due to a true increase of water content? So there can be different causes. Is it due to a true increase in water content? Is it because of a rectal storage issue? So this can be due to an ileus or an autonomic neuropathy, which can cause overflow incontinence. Or is it due to a proctitis issue? Or also don't forget hypothyroidism, which can also cause these symptoms. And when we're thinking about diarrhea, you have to figure out the timeline. So you have to differentiate, did it last a week? Or did it last multiple weeks? Or was it present for a few months? So if it was a week, we're going to call it an acute issue. If it was multiple weeks, it's going to be a subacute issue. And if it was months, it's going to be chronic. And then we have to figure out, does it occur at nighttime? Because if it occurs at nighttime, it may be secretory. Does it occur after food intake? That was not the issue with our patient, because this helps to rule out malabsorptive causes. Or was it osmotic diarrhea? And the first thing you need to consider when we're thinking about diarrhea is there inflammation present. So when we think about inflammation, look at the patient themselves. Is there fever? Look at the other vitals. And then we want to think about the 3 famous I's that Prof. Reza mentioned. So infection, IBD, or infiltrative disorders. Infiltrative disorders, this could be a malignant disorder as well. Second thing, you want to look at the labs. So is there leukocytosis? Is the ESR increased? Is CRP increased? The third thing you want to look at the stool. So what are the contents of the stool? Is there mucus? Is there blood? What's going on there? And then when we receive the HPI for this symptom, we want to think about the timeline of the symptoms. So what came first? Was it the diarrhea or was it the joint symptoms? So if the diarrhea came first, we want to be thinking about infectious causes. It could be foodborne illness. It could be IBD. But when the joint symptoms came before the diarrhea, we want to be thinking about autoinflammatory. We want to be thinking about infectious arthritis, reactive arthritis. And then we were thinking about the possibility of sarcoidosis. And if that's the case, we want to ask, in what way is this patient decompensating and in what period of timeline? And when we're thinking about sarcoidosis, we want to keep in mind two chronic mimics of sarcoid. So this can be either a foreign body, which is causing a granulomatous reaction. So this could be due to a silica being embedded, or any other foreign body, or it could be due to an immunodeficiency. And we also need to consider less common indolent infections as well. And then when we got the patient's physical exam and labs, we started shifting and started thinking from brain to peripheral nervous system issues. So in our patient, there was lower motor neuron and hyperreflexia. Now we're thinking, is this a peripheral nerve issue, or is it a peripheral nerve affected inside the cord issue? Because that could indicate cauda equina. And we were also thinking about demyelinating process. But when we're thinking about peripheral nervous system, we have to think about three things. Is it slowly progressive? Is it sensory predominant, or is it symmetric? And then we were thinking about fungal causes, but fungal causes, maybe not, because we did not have eosinophilia present. And then when we found out that the patient has thrombocytopenia, now we're thinking it could be GI, brain, joints, and bone marrow involvement. So now there's four major things that we can look at. And then we had our MRI results, which were negative. So now here we have two approaches, Prof. Reza's and Ravi's approach. So Prof. Reza's approach was, if there's a negative MRI, is it a nutritional deficiency? If it's negative, do other labs, send an LDH, which could indicate intravascular lymphoma, do an upper endoscopy to check for Whipple's disease, or is it a perineoplastic phenomenon? Rabi's approach, the second approach, is if the MRI is negative, think about it, divide it this way: intrinsic to the brain or extrinsic to the brain. So extrinsic brain disease, extrinsic diseases, it could be further divided into inflammatory or non-inflammatory or infectious. So when we're thinking about inflammatory, is it a intravascular lymphoma, just like Prof. Reza said, or is it a genital neoplasm? Here in this patient, because it's a male, we're thinking about testicular. Non-inflammatory, we want to think about anything that is initiated from the GI tract. So is it pellagra, if there's a B3 vitamin deficiency, or bismuth intake that could lead to diarrhea and confusions, or it can also be due to toxins. And then the third one is infection. So just like Prof. Reza mentioned, we agree on it could be Whipple's disease or an epidural abscess that is causing the altered mental status. And then, so that was extrinsic disease. And then intrinsic disease, it could be due to prion disease, which can cause diarrhea and neuropathy, or an autoimmune encephalitis. And then we also want to think, when we found out that it was West Island virus, we want to think about parenchymal intrinsic disease or meningeal issues as well. And yeah, that's what I have today. Thank you.
I think it was very, very hard to discuss this case. I think it was probably harder to put this case together in a way that made it presentable given its complexity. But I don't think anything comes close to the challenge of trying to weave this case in a narrative that made sense and that is understandable. That was amazing. Truly masterful case presentation, even rivaled by an incredible dissection of the case. Thank you. And I'm glad Prof. Reza and I could pad that with an average discussion of a complicated case. So thank you all. That was so much fun, and excited to see you guys, not tomorrow, but hopefully for student VMR. Bye.